I think now we can get started. Today we'll be discussing venous thromboembolism secondary to COVID-19 or COVID-19 related venous thromboembolism. And we have a presentation by Dr. Tinalo Molefhe. As always, just a few housekeeping issues before we start. These webinars are organized by the Ministry of Health together with the University of Botswana-Harvard Partnership, and Rutgers University. They are weekly webinars that we have on Thursdays, usually at 4 p.m. to 5 p.m. If you want to receive the invitation so that you know the topics ahead of the webinar, you can send your email to that email over there. All the sessions are over Zoom, and your mics will be muted until the point at which now you can start asking your questions and commenting. And this is after the presentation that will be made by today's presenter. We have a feedback survey as well that we send over email. There's one that we sent in this past week. If you haven't had the chance to respond to it, please do make the time, just a few minutes, to fill the feedback survey. This will help us improve these sessions so that they can benefit all of us in the future. So these sessions are recorded. That is the YouTube page where you can go to look at these webinars, previous ones, and this one that we are having today as well. We have the COVID-19 government portal. This is where we have different different documents or guidelines in relation to COVID-19. So you just go to that URL, you click on document library, and then you can have access to the different guidelines that have been developed so far. Okay, I think now we can go ahead and start our session for today. Like I said, we'll be talking about COVID-19-associated VTE, and the presentation will be done by Dr. Tinalo Molefhe, who is, sorry about that, who is a respiratory consultant leading both TB and PE services in the UK in Peterborough Hospital. She has been a respiratory physician for 9 years now. She's a Motswana who has worked in Botswana for a year in Marina in 2016 and 2017. So Dr. Molefhe, I'll hand over the mic to you now.
Hello, everyone who's joined the webinar. Thank you for giving me the opportunity to give you this presentation on this very difficult and interesting topic for all of us who've been looking after COVID-19 patients. So as an overview of the presentation, I'm hoping that at the end of the presentation, you would have known a little bit about how frequent this disease is and the mechanisms behind thrombosis in COVID, and how to manage our patients, both preventing the disease and also acute and chronic management of chronic thromboembolism. So as an introduction, COVID-19, as you all know, is an acronym for coronavirus disease. And this disease is caused by SARS coronavirus 2, and it has been shown to be associated with venous thromboembolism. the venous thromboembolism is normally associated, even without COVID, with severe inflammation and critical illness. And all these two factors lead to a prothrombotic state. Globally, a third venous thromboembolism is the third commonest cause of cardiovascular syndrome, and the incidence of VT has been increasing even prior to COVID-19, more especially in the elderly population. VTE has also been described in other viral pneumonia, and it's not unique to COVID-19, as with SARS and H1N1, although with less frequency. The true prevalence of the disease is really unknown at this stage. However, the cumulative incidence has somehow been described as, in some literature, as 17, but most literature has recorded it as about 24%. And obviously, it's more common in our sick patient with an incidence of about 50% in ICU patients and 18 in other medical or general wards. Whether this is a true incidence of the disease is difficult to know, because there is a phenomenon called immunothrombosis that is also seen in ads that could be contributing to the numbers that we are seeing and leading to overdiagnosis, as this cannot necessarily be distinguished from PE in our CT scans. The incidence of VTE as from the literature, as you can see, these three publications. The first one, which was overall VTEs by Middlecoff and Art, showed about 48% incidence in ICU patients compared to 10%. The second publication there, it was mainly for incidence of PE only, which showed also higher incidence in critically ill patients compared to non-ICU patients. And the last one was on DVTs only, and also the incidence there was higher in critically ill patients. So overall, those patients in critically ill, who are critically ill in our ICU or HDU units, seem to be more at risk of getting VTE. So then how do patients with coronavirus get VTE? There are three kind of mechanisms that have been postulated to be involved. The first one is endothelial inflammation, which leads to in-situ thrombosis and microvascular thrombosis. And this is the phenomena of immunothrombosis that I was referring to earlier. And this last two is altered blood flow with response to inflammation in the lung, and that can lead to more larger PEs in the pulmonary circulation. And so would be the last one, where there's the classical clot propagation and transition into the pulmonary arteries, embolic phenomena. So how do then the immune system cause thrombosis? So with COVID-19, we all know that the spike protein attaches to the angiotensin receptor 2 in the host cell, and in this instance, the host cell will be the alveolar epithelial cells, and enters the host cell. And this leads to viral replication and then apoptosis, which then recruits all the innate immune cells like monocytes and macrophages, which then leads to release of cytokine. And the main one that's been stipulated here is the interleukin 6, but you also have your TNFs. This then leads to a hypercoagulable state by three mechanisms. One is platelet release and activation causing platelet aggregation. The second will be activation of the tissue factors in the endothelial cells, which then leads to activation of both the intrinsic and extrinsic coagulation pathways. The third one will be release of plasminogen activator inhibitor due to increase in your TNF, leading to plasminogen activator TPA being inhibited. And all this leads to thrombosis. And this is a diagram of the description of what I've just said. The first mechanism, which the immune and inflammation will normally cause thrombosis in your distal pulmonary vessels. And the last one, where there is your DVT transition into the pulmonary circulation or disturbance of the pulmonary circulation flow, would cause the large thrombosis. Then how to then prevent this pulmonary embolism or VTE in COVID patients? The strategy or the optimal regimen to prevent VTE has not yet been established, and there is no actual international consensus as how we should do this. But at the moment, most hospitals or most countries are treating with different strategies, which include either standard prophylaxis, intermediate dosing, or therapeutic dosing. We have also realized that the thrombotic events, especially those occurring in patients in our critical care areas, are actually also happening when patients are on standard dosing. Most guidelines are saying that we should still consider prophylaxis for VTE, especially where there's thrombocytopenia, at least up to where platelets are above 30. In critically ill patients who are on unfractionated heparin, there's still a debate whether monitoring should be done by doing APTT levels, which are usually also disturbed in COVID-19, or should we be monitoring this using factor 10A levels. However, just this week, there has been a study published, or results published by these three study groups, the REMAP-CAP, Active4, and ATTAC study groups. And this has made the British Thoracic Society and the NICE guidance change from what has been the practice. Up until yesterday, in the UK, all patients in critical care areas were being given intermediate dosing for thromboprophylaxis. And those in the medical wards, general medical wards, were being given standard prophylactic dosing. However, this publication has changed practice, and the BTS and the NICE guidance have changed as of today to reflect what was found on these pooled studies. So about 2,000 patients who have been treated in these studies with therapeutic doses of low molecular weight heparin were found to have an increase in discharge without any organ support. About 4% of these patients were a lot better compared to those who received standard therapy. Hence, the guidance has changed, as you see on the next slide. Interestingly, those patients in critical care areas who were being given these therapeutic doses, the therapeutic doses did not result in any improvement in outcomes compared to standard treatment doses. Hence, the guidance has changed for our patients in critical care areas, as you'll see. So this slide is a bit busy, but it's basically showing most of the organizations that have been publishing guidance with regard to thromboprophylaxis. As you can see, in the UK, we have SIGN, which is the Scottish guidance, and NICE, which is the British. Both NICE and BTS are publishing as a single agent. So with SIGN, the guidance is still the same as of what the rest of the British IS was as of yesterday. So it's intermittent dosing for those patients in critical areas and standard dose for those in the ward. NICE has revised this to reflect what I've just said, that all patients in the medical wards will now be receiving therapeutic lower molecular weight heparins for at least 14 days or otherwise until the day of discharge. And all patients in the ICU or critical care areas like HDUs will need to be given either a standard dose or an intermediate dose. So it has not given any recommendation about what to do once the patients have been discharged. Prior to yesterday, they recommended 7 days of prophylaxis, but they're now saying that there's no evidence. As you can see, the Global COVID-19 Thrombosis Collaborative is for post-discharge prophylaxis is recommending up to 45 days. So moving on to diagnosis, as maybe all of you have experienced, diagnosis of VTE in our COVID-19 patient is quite difficult, especially diagnosing PE, because DVT possibly clinically could, especially if they're not necessarily in critical care areas. However, with PE, it's very difficult. And the usual predictive scores that we use, the Wells scores and the Geneva scores, have not proven to be quite useful in this scenario. The British guidance has now fallen back to clinical reasons for doing scans or for thinking that patients may have risk of VTE. And these would be dyspropionate hypoxia in comparison to the radiological changes, or if there is a clinical deterioration, i.e. increasing oxygen demands, a new tachycardia or arrhythmia, or a persistent one, even with treatment, or a significant drop in blood pressure. All these things are the more reasons to think about P in your differential if they happen to your patients. However, there have been a number of studies done, and these have kind of brought in quite some debate as to whether we should be using D-dimer as an indicator for possible PE. The reason being, with COVID-19, most patients do have elevated D-dimers, but a number of studies have noticed that those at high risk usually have more elevated D-dimers, and there have been some who have been doing serial D-dimer levels to determine whether they should be doing CTPAs to check whether their patients are having VTE or not. Another school of thought would be to check your cardiac enzymes, things like troponins. They have been found to be quite elevated in those who are subsequently diagnosed with PE compared to those with no PE. However, one disappointing thing is that the rise in pro-BNPs has not been significantly been associated with VTE, as one would expect, given that those people with high or significant clot burdens usually have right ventricular dysfunction, leading to rise in pro-BNPs. Other things or markers or biomarkers that have been found to be elevated in patients with VTE would be things like liver test or liver function tests, things like arterial carbon dioxide tension, elevation in bicarb levels, which is surprising because usually patients with VTE, they have type 1 respiratory failure, which is not usually associated with a rise in bicarbonate levels. Also, one other independent risk factor for VTE is itself an admission to an ICU unit. So then looking into the D-dimer use in COVID-19, as we have seen, some centers are using D-dimer to distinguish whether patients are more at risk of VTE or not. Remember though, D-dimer prior to the COVID-19 pandemic was a rule-out test. So if patients came in with low preclinical probability of PE or intermediate probability of PE, that's when we used to do a D-dimer to exclude PE. And a positive test was not used to predict whether patients have PE or couldn't predict whether patients have PE or not, because D-dimer is elevated in other inflammatory conditions and also in thrombosis. So with regard to our British colleagues or British organizations, NICE, British Thoracic Society, they recommend not using D-dimer at all or in isolation, and they have strictly stressed that the D-dimer should be used in conjunction with the clinical picture. So looking at the studies or evidence out there, and there have been a number of studies that have been looking at D-dimer and how useful it may be in predicting risk of PE. And most of these studies have come up with different optimal threshold levels where we should think that the patient may have VTE, ranging from about 2,500 nanograms per ml to about 4,800. However, what's disappointing is most of the studies is that the specificity of the test has been in the lowest range, which is not quite good for a diagnostic test. So carrying on to which test then, if you think your patient has high risk of PE, what is the best diagnostic test to do or imaging modality? The CTPA or a multi-detector CTPA has been recommended as the best treatment or imaging modality. It has a sensitivity of about 83% and specificity of 96%. However, as you may all know or have experience is not always practical, especially with critically ill patients, because they may not necessarily be stable to be transferred over to the radiology department, especially if it's far, and more especially in patients who are on CPAP, because as you know, CPAP is aerosol generating procedure, and you may not be you may be spreading infection. From infection control point of view, it may not be practical to get your patients to the radiology department for scan. However, this is the test that will tell you whether your patients have PEs or not. But as we have already touched on, it doesn't differentiate between PE and immunothrombosis. Then another test is a VQ scan, and most of the literature does not recommend using VQ scan, mainly because our patients with COVID-19 have concomitant pneumonia, and you will not be able to see your mismatch with an abnormal scan. Also, the ventilation part of the scan is also aerosol generation. With regard to echocardiogram, it has been useful, especially in patients in critical care areas or those who are hemodynamically stable. However, the only problem with this test is that sometimes right ventricular dysfunction also happens in patients who just have ARDS and not necessarily have PE. So, but it will be useful, especially if patients are low risk in terms of bleeding. However, if your patients have high bleeding risk, you are really forced to try and get a CT PA to exclude VTE in that scenario. Ultrasound or venogram is used to diagnose VTE, and we usually use it as well in pregnant patients who may not necessarily be suitable to have CTPAs or VQ scans. So in terms of management of PE for stable patients, oxygen therapy, ventilation if they need ventilation, and amine saturations over 92, 94%. Here in the UK, currently we amine sats of 92 since the COVID pandemic. And also using anticoagulation. The first thing with anticoagulation for any patient is to make sure that you've also assessed their bleeding risk. Consider drug interactions, especially with some antivirals or interleukin-6. In the context of Botswana, it's usually lower molecular weight heparins and vitamin K antagonists. So I'm not sure if you are using NOACs as your first line. However, most of the countries in the developed world are using NOACs in the first as first line, and usually most NOACs, especially rivaroxaban and apixaban, which are mostly used, they do not need any bridging therapy. You can start it without having given lower molecular weight heparin first. Now then, what about treatment in a hemodynamically unstable patient? And this is described as a patient who has either persistent drop in their blood pressure, less than 90 systolic, or a drop more than 40 millimeter HT, or a patient who has a circulatory shock or a cardiac arrest. So in these patients, the treatment would be to treat the right ventricular failure. You can give fluids, maybe up to 500 ml, but also strict monitoring of central venous pressure, and also consider giving vasopressors. Reperfusion is the treatment of choice with thrombolysis, like alteplase, and you usually need to give unfractionated heparin prior to giving your thrombolysis. However, be mindful of contraindications, especially in our COVID-19 patients who may also have concomitant coagulopathy or DIC. Remember, in this scenario, the coagulopathy and COVID-19, they would have high D-dimers, probably not low platelets as much as the other DIC patients, and the fibrinogen is not usually low as would with the classical DIC. Also, other contraindications in our COVID-19 patients will be things like thrombocytopenia and those patients in extremes of age. But as you know, with PEs, all these are relative contraindications. So then looking at this, just an algorithm of how to manage the patient who are hemodynamically unstable. You can do a bedside transthoracic echo. The transthoracic echo would then let you know whether the patient has right ventricular dysfunction or not. And if they don't, then you need to look for other things while your patient is in shock or they're hemodynamically unstable. If they do have right ventricular dysfunction, and you can do a CT PA. If it's feasible, if it's not feasible, you would be advised to treat SP. If it's feasible, you can do a CT PA to exclude PA. So once you've treated your patients and they're now established on their anticoagulation, they're ready to be discharged, most guidance would advise that your patients are assessed within 3 months or 6 months of having had the PE, mostly to exclude chronic complications like chronic thromboembolism or pulmonary hypertension, with or without pulmonary hypertension. And the test that we would normally do to assess for that will be your 6-minute walk test. In other centers, cardiopulmonary testing will be performed. Usually, we perform cardiac enzymes like BMP, troponins, and also assess symptoms and usual clinical examinations. If your patients following these investigations, they'll be assessed whether they are high risk, low risk of pulmonary hypertension. If they're high risk, then you would do your echocardiogram, and following which you can do either a CTPA or VQ scan. However, in our practice here, we would normally do a CTPA first, and if the CTPA was negative, you'll proceed to do a VQ scan because it has a higher sensitivity for low order PEs. And the plan would then, if they do have chronic thromboembolism, to refer them to tertiary centers for further management and treatment. The NICE guidance is advocating for treating or recommending treating VT secondary to COVID for 3 months. But our practice or our experience is that sometimes after 3 months, patients are still symptomatic and you still have to continue and reassess them at 6 months time. And we have had a few patients who have gone on to develop chronic thromboembolism following the COVID-19-associated pulmonary embolisms. So in conclusion, venous thromboembolism and COVID-19 is really a rapidly evolving area, and current guidelines are not set in stone, therefore they should be viewed as temporary, and as they are rapidly changing. The diagnosis of ET in COVID, as I've described, is quite difficult, and really we need to go back to the clinical and really so that we don't end up scanning everyone or over-treating, I must say. Currently, there's no international consensus on the optimal strategy or regimen for thromboprophylaxis for all patients with COVID, depending on the clinical areas or severities, or what to do with prophylaxis post-discharge. Treatment with anticoagulation should always be balanced with bleeding risks, and this should always be reviewed even when they develop chronic thromboembolism. The continued assessment of both recurrence risk and bleeding risk should be an ongoing thing. The role for D-dimer and thresholds for D-dimer is still under investigation. And lastly, we do really run a risk of ending up investigating or over-investigating with CTPAs, which would invariably lead to increased costs to our healthcare systems. And these are my references, and thank you for your attention. Any questions?
Thank you so much, Dr. Molefhe. With COVID-19, it's really, it becomes difficult to stay up to date with all the incoming information. So we really appreciate you taking the time today to share that guidance and new information with us. The first question on the chat is from Dr. Mugadi. He says, which criteria can we use to start prophylaxis treatment in COVID-19?
I suppose the last one, maybe I'm being biased, the NICE guidance is based on the latest 3 studies which were across countries, were not in just one country. And those studies that I showed there looked at about 2,000 patients, and they were randomized control trials, and which is why they forced NICE to change its guidance from today. So I would go with that. But obviously the difficulty is once you've given your patients your prophylaxis after 14 days, then what? Because I think we do run the risk of not going with the guidance and not looking at patients individually, because I'm sure some of those patients that you give prophylactic dalteparin, who, as per guidance, would be missed as this was per guidance, when actually the person who initially prescribed was thinking there may be VTE, and they should proceed and have a CT scan to exclude it. So I think it's kind of leaving quite a gray area as to what would happen on the ground. But I would go with it because that is what, because giving prophylaxis in our HGU or critical care areas, that or either the intermediate dose or the therapeutic dose has been associated with more risk bleeding events, which is why the guidance has changed to just prophylaxis doses for those areas and individually assessing each patient's. If you think they have VTE, treat them with therapeutic lower molecular heparin before, and then scan them once they are ready to be scanned. But I don't know. It's really up to I would say whoever is managing your COVID-19 pandemic, and to sit down and decide which guidance they actually go with and which evidence they would consider to be a higher level evidence. But because most of the other studies or most of the other recommendations were not necessarily based on large pool of evidence, and also not RCT, I would go with the latest evidence that NICE is using.
Wonderful. Wonderful. Thank you so much, Doc. I see 3 hands from Dr. Naxted, Dr. Mushomo, and Dr. Macheng. In that order, I think we'll take all the questions and then you can respond to them later. Dr. Britt, you can go on with your question.
Yeah, thank you. I think I have one comment, a question. I'm from the Department of Pediatrics and Adolescent Health. And although it's ages ago, my PhD was on coagulation and fibrinolysis systems. And back then, I learned that D-dimer was a very sensitive measure for that some coagulation is going on, like in venous thrombosis and pulmonary embolism. So I'm a bit surprised by the results you showed, because it's so easy to take a blood test. And I have been thinking that if the D-dimer is 0, you should just relax in a way regarding the hypercoagulability state. But if it's elevated, it's something. So maybe these patients should very soon be transported or admitted to the intensive care and be candidates for ventilation as well. So that's my thinking, but it's a long ago since I was in adult medicine. But the question is, in my department, in the neonatal unit, we have been having all these deliveries of mothers with COVID-positive disease. The babies are well, but I think 10 or even more of the moms, they die. And this is interesting because pregnancy itself is a hypercoagulability disorder. It's known that they have increased coagulation factors and things. And in addition, you get these COVID triggering intense inflammation, which trigger all the cascade systems in the body, leading to multi-organ failure. So, but I've been told that these moms are not put on the vent and probably have pulmonary embolism. So I'm worried for the moms and of course the babies that lose their mom. So I'm wondering, is there a protocol? What do you do with this COVID positive delivering women? So dramatic that they pass. I was also discussing this with the head of the delivery unit. So yeah, I'm worried. So that's all from me. Thank you.
Thank you so much, Dr. Britt. It is concerning. Dr. Mushumo.
Thanks. Thanks, Dr. Tinalo, for the comprehensive and clear presentation. I have 3 questions here. The first relates to one of your initial slides on the heightened risk of thromboembolism in elderly patients. And you said like 8 times higher risk compared to other populations. I was just curious as to why the elderly have such a higher risk compared to other populations. And then the second relates to the article that you did share, that you said changed the practice of anticoagulation in the UK. It's a bit surprising because intuitively one would think that patients who have critical illness from COVID, because of the increased inflammation in them, would actually be at a better chance of benefiting from therapeutic anticoagulation compared to non-critical patients. So I was just wondering why the findings from the study actually turned out that those with non-critical illness from COVID hospitalized had benefit compared to those with critical illness. And I was just wondering if it's just because of the extent of lung damage in those with critical illness that even with therapeutic doses anticoagulation, what was driving the mortality and illness was rather the respiratory failure and lung damage and not necessarily venous thromboembolism. And because I think if that is the case, then it still raises a question as to whether it's justifiable to then say those with critical illness will just give them standards prophylactic anticoagulation and not full dose therapeutic anticoagulation, but continue that therapeutic for non-critical illness. I hope it makes sense. And then my last question was just curious, in the UK, do all patients get like a routine CT chest, whether on admission or at any point during hospitalization? And then just lastly, as a comment, maybe just to give a South African context, at Tygerberg, all hospitalized patients with COVID, we give them therapeutic dose, low molecular weight heparin, both ICU and non-ICU. There are a few in the ICU who will do unfractionated heparin and monitor the factors and air levels.
Okay, thank you so much, Tato. Dr. Maching, your question.
Thank you, Dr. Molefhe, for this wonderful presentation, and also for listening to some of the difficult questions from some of the participants. Mine is more of a practical question. It relates to the fact that most patients, when they come into the hospital, they're very unstable, and you can't really decide to send them immediately to the CT scanner. So sometimes you find that clinically you think somebody has a PE, and the CTPA is only done more than 5 days after therapeutic anticoagulation. Even some rare cases, we have done CT scans on day 12 of admission. So in terms of discharge planning for these patients, how do we treat them? Do we treat them as likely that they had a PE, it resolved if the CTPA comes back negative? Or should we consider them to not have had PEs in the first place and discharge them home without anticoagulation? That was my my question, and I've always faced this question when I was looking after the patients in Princess Marina Hospital. Thank you.
Thank you very much, Dr. Macheng. I think we can pause here, Dr. Molefhe, so that you can respond to the questions that have been posed so far. Dr. Mukadi, I'll get to you.
So I have a confession to make. I don't think I had the other comments. I only had Dr. Macheng and Dr. Moshomo's questions because my line was cut for some time. So anyway,
Yes.
for Dr. Macheng's question, let me start with that one. Usually, even if you've done a CTPA at about 12 days, because that's what we normally do. We delay our CTPAs on CPAP, or you can't practically get them to the CT scanner until they're on normal masks or Venturi masks. So we normally delay their CT scanner. But what we find is that if they do have a PE and you've only given lower molecular weight heparin, the blood clot should still be there even after 12 days or so. So it doesn't necessarily disappear, because remember, your anticoagulation does not dissolve the clot. It only stops further clot propagation. Your body should dissolve the clot in time. So you should still expect the blood clot to be there. If it's not there, then it was never PE. However, if the scan is delayed for a very long time, maybe a month or so, and you do the scan and it's not there, and you thought that the patient did have a PE, I think you should continue give them at least 12 weeks of the anticoagulation. It will be reasonable to do that and treat it as a PE. With regard to Dr. Moshomo's and with regard to this study that showed that the thromboprophylaxis had bad outcomes in critically ill patients, I would think because some of the autopsies for critically ill patients, for patients who died of COVID, have shown that the lung or the pattern of lung injury in most of them is actually diffuse alveolar hemorrhage. So I think that, in a way, sort of may explain why there were bad outcomes in those patients compared to the non-critically ill patients. That would be my understanding. Yes, you are right. Heparin has anti-inflammatory properties. I mean, even lower molecular weight heparins also have antiviral properties as they inhibit your spike protein. So you would expect a better outcome with patients who are sick in critically ill areas. But also we should probably look at the actual pattern of the lung injury that they have, which is hemorrhage, and giving them more blood thinning medication may be the reason why they were bad outcomes in those patients. Hello?
Okay, Ngaka. Makes sense. Thank you so much. The question from Dr. Britt, the one that you missed when your connection cut.
Yeah.
Hello?
Yes.
Emma. So she was saying that they have noticed that in the neonatal unit where she works, a lot of the babies are delivered well. Babies born to COVID-19 positive mothers are delivered well, but most of the mothers, a large number of the mothers, end up passing away. So she found this interesting and worrying. Her question was, is there a protocol for these mothers who go to delivery having tested COVID-19 positive, who will possibly have a pulmonary embolism? Is there a protocol for them?
I don't think in the literature that I looked at, I specifically looked at pregnancy and VTE, but obviously pregnancy in itself is a pro-thrombotic state, and having had COVID on top of pregnancy. So my feeling would probably be they should probably, if I were risk assessing them, I'll probably advise therapeutic lower molecular weight heparin for at least 6 weeks post the delivery to stay on the safe side. I don't know if that is the right thing to do, but if you tested positive and you are now postpartum, probably you should stay on lower molecular weight heparin unless there are other signs that you may actually have PE, then in that case, you should actually, after the delivery, maybe do the scan and to exclude the VTE. I would think that would be the rational thing to do, but I don't know if there's actually any consensus or international guidance on that.
Now, so my point was also that being pregnant is a hypercoagulable condition.
Yes.
So you should be very aware. And I was told that these delivering women are not put on the vent. So I didn't understand why we don't do this.
I think we have actually about we've had about 3 or 4 patients here who've had COVID, but they were not about to deliver, but they were all on the ventilator, non-invasive ventilator, on the CPAP. But we have actually had one patient who was in ITU intubated and ended up having a baby whilst intubated. She woke up extubated about a month later. So I don't understand why your guidance is not to intubate them.
I think it's more than 10 moms that have passed.
Oh,
Yeah,
we have been giving them ventilation here, so I don't know why.
Yeah.
Can I weigh in?
Yes.
I actually looked after patients with COVID in Princess Marina. We had a severe shortage of ICU and CPAP units in the country. So we actually were running the country with about nine ICU beds and less than 10 CPAP units. And most of them were in Sekitumile. Only in Marina, we were doing some bridging of patients. Either we'd intubate you if you needed to be intubated, or we would put you on CPAP and then transfer you. During the peak of the wave, we actually had patients dying because they couldn't get into the CPAP units because they were not available. Like there was 100% usage of the bridging CPAP units in Marina, which were available in Marina, and even in Sekitumile during the peak, there was severe shortage of CPAP. Sometimes we'd even intubate patients for more than 10 days in Marina. So I think in terms of going forward, because we've been trying to advocate for more ventilators to be available in Princess Marina so that we can use them as a bridge. I think the 10 patients that died pregnant can be a good tool to use in terms of convincing the powers that be that we really to bridge patients before they go to Sekitumile. I also personally have lost a lot of patients because there was nothing to help them with in Princess Marina.
Yeah, thank you so much, Dr. Machin, for pitching in. So it might not necessarily be that there's no protocol. It might just be due to the unavailability of ventilation machines that you mentioned. Dr. Mukadi, I'm so sorry. I realized that you've had your hand up for some time, but unfortunately we've run out of time. If it's possible, Dr. Molefhe can share her email with us, then you can forward your questions or your comments to her. Thank you everyone who have participated, everyone who's stayed on this call, and thank you again, Dr. Molefhe, for making time to share this knowledge with us. I think the reason why we had so many questions today is because there's still really upcoming information on VTE in COVID-19. That's why a lot is still unknown, especially when it comes to the right treatment modalities. Thank you, everyone. Dr. Mukadi, please do note Dr. Molefhe's email on the chat and have a conversation with her on the email there. I'm sorry we can't have your question now. We've run out of time. Thank you so much, everyone. See you again next week. I don't know if there are any announcements from Dr. Lebilonyani and Vusi. Any announcements?
Just that next week we will have, we will go back to DHMT updates from Mahalape and from Tutume DHMT.
Okay, that's great. Thank you so much. Thank you, everyone. Have a wonderful evening.
Okay, thank you.
Bye.
Bye.
Thank you.